Hello, I'm Chris Kruger, Senior Manager for Content with the Davis Phinney Foundation. Welcome to the July 2026 Live Well Today webinar. This webinar series is supported by our peak partner, Amneal, and we appreciate their support, as always. Dr. Tagliati, before we jump into today's topic, which is dystonia and Parkinson's, I wonder if you can give a quick overview of your background in Parkinson's and how you came to work with people with Parkinson's.
Yes. First of all, Chris, thank you. And thank you to the Davis Phinney Foundation for inviting me today. It's truly an honor and a privilege to be able to speak to such a large audience. I see more than 300 people. This is going to be wonderful. I am a neurologist and a movement disorder specialist. I started to work with patients with Parkinson's disease a long time ago. I trained originally in Italy at the University of Rome, where I actually started already to work with patients with Parkinson. Then I moved to the United States. I trained again, but I kept that original interest in movement disorder and Parkinson's disease. And so I ended up going back and becoming a specialist in the United States. I was very lucky, as I mentioned to you earlier, to train with some of the giants of movement disorder and dystonia, particularly like Dr. Susan Bressman in New York. At the time in which dystonia, on one hand, became a neurological disorder, many may not know that dystonia in the old days, like in the 60s and early 70s, was considered a psychiatric disorder. In other words, patients were thought to kind of make it up. Which was sad. Dr. Stanley Phan was the one that historically brought the dystonia into the neurological disorders. And also at the time, I was training when botulinum toxin and the brain stimulation, two of the incredibly effective treatment that we have for dystonia, started to get developed. So I can say, at the right place and the right time. And that made my interest for dystonia more and more of a specialty trait. So we now at Cedars-Sinai, where I practice, where I'm the director of the Division of Movement Disorders, we see a tremendous amount of patients with Parkinson's disease, but also we specialize in the diagnosis and treatment of dystonia, as we will discuss, either primary or associated with Parkinson's disease.
Yeah, so let's jump into that. I think there's a question. What is dystonia and how does it relate to Parkinson's? Because there's different types, right? I mean, there's primary dystonia and there's Parkinsonia. So tell us about that. What is dystonia? How does it relate to Parkinson's?
So the official sort of definition of dystonia is the one of involuntary, sustained, typically patterned, meaning that they tend to have a repetitive manifestation. Muscle contractions, basically, that force, in many cases, parts of the body to assume involuntary, sometimes twisting postures, sometimes very dramatic postures. Sometimes it can be tremulous or jerky in a different way as the typical resting tremor or Parkinson's disease. And these dystonic movements tend to be associated with movements. So they tend to be started with the movement. They tend not to occur when you're like sitting on your chair. Primary, as I mentioned earlier, can be a primary disorder of its own. We can talk a little bit about that later if there is a chance. It can be secondary to a number of medications. Most of them related to the dopaminergic system, and intuitively is also associated with Parkinson's disease as a symptom of the disorder. It can occur as a symptom disorder just as much as resting tremor or rigidity or bradykinesia, and but also, and that makes it a little bit confusing and complicated sometimes, as a side effect of dopaminergic treatment and levodopa in particular. So sometimes dystonia may have a different color for patients with Parkinson's disease. Some may experience it when they're off medication, so to speak, and others may experience it when they're on medication, similar to, but not completely equal to dyskinesias, for example.
So there's a lot of nuance in what you just said, and I think that's one of the problems that people with Parkinson's face when we are dealing with dystonia. And I should say real quickly that I happen to have Parkinson's myself, as many people in the audience may know, but not everybody. So I just want to say that up front. And I guess, on top of the difficulty of treating it, there's also the difficulty of recognizing what the cause of the problem is. So we may not even necessarily recognize that it's dystonia. So maybe that's a good opportunity to ask a sort of follow-up, which is maybe, are there groups of people that are more likely to experience dystonia, and do we know why? Or is it just sort of even between all people with Parkinson's? Is there a way to talk about that subject intelligently or reasonably?
Absolutely. So it doesn't occur equally in every patient with dystonia. Patients with young onset Parkinson disease, which by definition is when the Parkinson starts earlier than age 50, tends to have a higher incidence of dystonia. It's not fully clear why that might be. However, because the basic problem is that we don't know exactly what dystonia is. But one of the theories behind dystonia is that it is a phenomenon of maladaptive plasticity. Plasticity, as you might know, is the ability of the brain to change, right, in response to experience, challenges, sometimes stress. And one theory behind dystonia in young onset Parkinson is that the stress, for lack of a better term, caused by the decreased dopaminergic input in the basal ganglia might force the brain to rearrange literally its mechanism. And this rearrangement, this plasticity, might become maladaptive. In other words, the brain may start having difficulty picking and choosing the muscles to activate. And so agonists and antagonists, let's take a step back. What does it mean, agonists and antagonists? Every time we make a movement, I don't know if you can all see my hands. Let's say that I'm going to say, I want to close my hands and open my hands. If I want to close my hands, the brain needs to activate my flexors. I need to flex my fingers and release the extensors. Then if I want to open my hand again, I need to activate the extensors and let go with the flexors. Now, just imagine a situation in which my brain doesn't know exactly how to do that. And so my hand starts twisting because at the same time, I want to activate my extensors and my flexor. That is dystonia in a nutshell. And so you can imagine if the brain is trying to rearrange things secondary to the disease, making the dopamine function less effective. Some patients, especially when young, when that plasticity is more powerful, might be more predisposed to develop dystonia. But this is, I have to say, is a speculation. It's not a scientific rule, although it is something that is good to study dystonia, under this premises.
Yeah, it's interesting. You think about neuroplasticity as being maybe a benefit for having a younger brain. Maybe whether that's true or not, I think is maybe not my specialty. I shouldn't speak on that, but maybe in this case, it's not actually an advantage.
Correct. Plasticity is a great thing. That's the basis of our learning, of our acquiring skills like a violinist or a tennis player, or just walking, or just using our limbs in a sophisticated manner. But it can get wrong, and that's where probably there is a genetic predisposition. And in fact, in young onset Parkinson disease, there is probably more incidence of genetic variants and genetic predisposition to develop Parkinson disease. And going back to that primary dystonia that I mentioned very quickly earlier, probably that's why very young people tend to get into dystonia. Or to just add another level of complexity, why musicians tend to develop dystonia is musicians force their brain to learn incredibly sophisticated pattern of activation and the activation of their muscles. Just imagine a piano player or a violinist, as I already mentioned. And you can imagine how when you develop these very sophisticated softwares, you can get into glitches. And so someone actually called dystonia a computer virus or a glitch that makes it difficult for the brain to activate muscles in the right sequence.
So speaking of glitches, can we talk a little bit more about the medication issues that are at play in dystonia, just to sort of round out that part of the conversation? I think you said that you can have it when you're in an off state, or you can have it when you're in an on state. And can you just fill that out a little bit and maybe describe a little bit how this relates just generally to on-off fluctuations?
Absolutely. There are two parts when we talk about medications and dystonia. There are certain medications that hopefully patients with Parkinson do not take, which are anti-dopaminergic medications like neuroleptics, for example, that can cause acute dystonic reaction, which are completely independent of Parkinson's disease. Similarly, a drug of abuse like cocaine, which, as we know, do affect the dopaminergic system, can also trigger dystonia, independent of having Parkinson or having any other movement disorders. But focusing on Parkinson's disease, the medications on focus is obviously levodopa or other dopaminergic medications that can trigger dystonia. And that makes the patients and the doctor work a little bit more complex, because we need to investigate if a patient come to us and say, my foot, my toes are curling, and my foot is contracting. I find it difficult to walk. This is a very, very typical, probably the most typical type of dystonia in Parkinson. We need to figure out whether that is a symptom of the disease or is a complication triggered by levodopa or dopaminergic medications. How do we do that? In great part, trying to figure out the timing of this problem. For example, if someone wakes up in the morning and his foot is curling down before they take their early morning medication, that is most likely a symptom of the disease, which is untreated, typically in the morning, but can come back during the day, for example, as a consequence of a wearing off, which marks the more advanced stages of the disease. If instead the same exact manifestation, same exact curling of the foot occurs, let's say 1 hour after taking the usual dose of levodopa, that is most likely a side effect of taking medication. I know it's confusing. How can that be both ways? But this is fundamental, because in one case, obviously, we may need to increase the medication or to adjust the dose or the timing of the medication. In the second case, we need to cut down the levodopa if we can. Most of the time, I have to say, we don't do that, because that would force our patients to change medication doses that are very effective for other aspects of the disorder. And we instead add on other treatments like botulinum toxin injections, most frequently, which is extremely effective and does not interfere with our general medical treatment, or treatment that are more specifically medications that can treat dystonia, like anticholinergics, baclofen, some benzodiazepine. I don't want to get into too many specific treatment for obvious reasons, but just to say that we have other solutions that would not require messing around with a maybe finely tuned, dopaminergic treatment, levodopa doses. I hope I answered your question.
Yeah, you did. And I think we'll get to those other parts of this, the medication part of the conversation, the sort of what do we do about this problem in a bit. So yeah, I think you did cover it from my perspective. I think we've also gotten some questions in the chat that relate to this sort of entryway to talk about dystonia. And one of the questions is, can you talk about the difference between dystonia and dyskinesia and what the relationship between the symptoms are of those two conditions or side effects?
Yes, absolutely. It's not always easy to distinguish them. They're both what we call hyperkinetic disorders, so overactivation of our muscles, of our movements. but they can be defined. Dystonia tend to be a more sort of static, a more intense contraction. As I said, maybe bringing in a forced posture, an abnormal posture. But the dyskinesia in comparison is a much more fluid. In fact, someone call it chorea, right? Dancing. Dyskinesia tend not to be painful, tend actually to be associated with a very good function. I mean, many of my patients, if the dyskinesia is mild, they don't mind to have dyskinesias because that is associated with very good response to levodopa. Well, the dystonia is most often either painful or disabling, like it doesn't allow you to use that hand, that foot, the trunk or your head. So dystonia is more of a forceful contraction of your muscles. Dyskinesia is more of a fluid, involuntary movement that, however, tends to be a little bit less disabling, unless it becomes very severe, and then it kind of throws you off your regular balance and your regular coordination.
Thanks for that clarification. I'm wondering if you can tackle this question from the chat as well, which relates to something you previously said, which is, and I don't know if you're going to be able to do this one, so forgive me if I'm putting you on the spot here a little bit. The question is, can you choose one of these answers? Dystonia is caused by Parkinson's or dystonia is caused by medications?
Oh, no, it's caused by both. It's not Sophie's choice here. It's like I take both of my children with me, meaning that the challenge is to figure out which one it is, but it is caused by both. And this is common experience. In a young patient with Parkinson, it's probably more likely that is a primary effect of a primary symptom of the disease. In an older individual, it may be more of a consequence of the medication. But at the description classification level, dystonia can be a primary symptom, so an off medication problem, and or a on medication. I have to say that while I'm talking, I'm thinking it's like it can be both in the same subject. And I guess theoretically, yes, but I tend to think that it's either one or the other in a single individual. But in general, it can definitely both. If you read any review, textbook, dystonia is classically defined either as a primary disorder, a primary symptom, or a complication of the medication. And that's what we need to figure out in order to help our patients.
So that's actually sort of the flip side of the question I was going to ask you next, which is, that sounds really challenging, the fact that this could be both ways for the clinician and also for the person with Parkinson's. So what can we as people with Parkinson's do to help our physicians get to the bottom of that question more effectively? Can we bring data to them when we go to a visit? What can we do to help?
That's a wonderful question because in general, I love this type of collaboration between patient and doctor, especially in Parkinson's disease, which is a chronic disorder. In fact, we are now piloting, and I don't want to talk about this in too much details, but a monitoring a patient with Parkinson, not seeing them, every 4, 6, 8 months, but monitoring more continuously, because I really believe in the proactive action of patients. So what, going back to dystonia, can our patient can do? Well, as we mentioned, they can look into the timing of the dystonia. Is that something that happens before I take my medication or in the full sort of on phase of my levodopa dose? Is this something painful? Tends to be more dystonia than dyskinesias. Is this something that is disabling, meaning it really is something that the doctors need to jump on, or is more something like that I observe, but it doesn't get in the way of my day? Now, every involuntary movement, as far as I'm concerned, is disabling because it reduces our ability to use our body freely. But definitely the timing, the pain component is something that if you get to your visit already with this information, and you don't need to think and to go back and maybe wait another follow-up to study, when this abnormal movement come in, can definitely help your doctor making a determination quicker.
Okay, yeah, thanks for that information. It can be a real challenge to know how to help, and so thanks for giving us that insight. I wonder if we should maybe jump into talking about how some of these ways to manage dyskinesia. I keep saying dyskinesia when I mean dystonia. Managing dystonia. So, and in particular, a couple of people have asked some questions in the chat that maybe relate to my first question that I had planned to ask you, and so I'll try to lump these two together if I can. Basically, the first question I was going to ask is, what lifestyle things can we do as people with Parkinson's to help ourselves manage dystonia? I mean, is timing of exercise a factor here? Is there anything we should think about with regards to hydration, which is a question that came in from the chat? What about supplementation? I think sometimes people think about magnesium for things like relaxing muscles. And so what do you think about that subject? Is there anything we can do lifestyle-wise? Does hydration matter? Are there any supplements? Can we start there with thinking about how to manage dystonia?
Absolutely. The answer is yes, but we need to understand one thing. So the supplement and the magnesium and the hydration have to do with muscle cramps and contractions, which is a muscle problem, which can appear, at the end of the day, the feeling may be very similar, but it's not dystonia, it's a muscle cramp. So it's definitely a good idea to always be well hydrated, and to always, make sure that the muscle itself is not a victim of some, metabolic dysfunction. But dystonia is not in the muscles. The muscles are the innocent bystanders of the problem, but the problem is in the brain. And so it's very difficult to control our brain. But, and it's a big, beautiful but we can do something. Definitely, we can pay attention to our sleep patterns. Everybody who has Parkinson's disease, and even if they don't have Parkinson's disease, know well that if the difference in our daytime functioning, if we sleep well and if we don't sleep well, is dramatic. The response to the medications is much, much better if we sleep well than if we don't sleep well. So one thing that can be done in general, because this is a symptom of Parkinson's disease again, is to make sure that our Parkinson's disease is not unnecessarily worse due to lifestyle matter, like, for example, not being able to sleep. The other interesting part of the lifestyle story is exercise, because it's a little bit of a conundrum there, because exercise itself can trigger dystonia. And so one may be caught in between, oh my God, my doctor told me I have to exercise because exercise is good for Parkinson, and there's no doubt about that. But then if I exercise, I get dystonia. So what should I do? Should I avoid exercise? The answer is no, you shouldn't avoid exercise, but should definitely be careful of always exercise on medication, assuming that you don't have an on dystonia, of course. And make sure that, as soon as you feel that tightening maybe of the foot, you slow down. In other words, you time your exercise and its intensity to avoid getting into dystonia area. And that can be a little challenging, but it can be mastered. It can be definitely, there is no reason to stop exercising, because exercising can trigger dystonia, but definitely needs some more attention than someone that fortunately the majority, 70% plus of patients with Parkinson don't have any dystonia, and so they don't need to pay attention to that. But so sleep well, exercise, but if dystonia is part of your symptom complex, pay attention to exercise always, well on medication, and without pushing it too hard, that can trigger dystonia.
I think maybe I'd like to see if we can drill into the medication approaches in terms of pharmaceutical interventions like carbidopa-levodopa. I realize that you've already said that this can go both ways. You can have it when you're off, you can have it when you're on. So can you just say a little bit more about what are the common strategies for navigating the question of how medication is involved in somebody's experience of dystonia. Obviously, you can lower, you can raise doses and whatnot, but can you just talk a little bit about the adjustments that are possible?
So let's say there are three types of adjustments that we can make in general. One is to adjust the levodopa, the carbidopa-levodopa or dopaminergic medication dose and timing. So we can optimize the dose if we feel that dystonia is a primary symptom of the disease, that the levodopa maybe is not properly controlling. We can change the frequency of the medication doses if we notice that there is a wearing off, for example, that is expressed by the dystonia sort of coming back. And in general, we can try to control dystonia just adjusting, optimizing the dose of levodopa. If that is not possible, because of so many reasons that we don't need to list in this moment, we can use two other strategies. One, which is, as I mentioned already, probably the most effective in general, is injections of botulinum toxin in the muscle or muscles groups that are affected by dystonia. Why do I like it so much? Well, first of all, because botulinum toxin is extremely effective for dystonia, independent of Parkinson's disease. We inject an enormous amount of patients with dystonia, focal dystonia, with botulinum toxin very, very successfully, but also because it doesn't interfere with our general management of the disease. So we don't need to mess around with the timing, with the doses of carbidopa, levodopa, of dopamine agonists, whatever we're using. We can literally surgically almost take care of the dystonia without creating trial periods, try this, try that, maybe it will work, maybe it will not. The third possible scenario is to use, as I mentioned already, other type of medications, which interestingly enough can be used also for Parkinson's disease in general, like anticholinergics, for example. However, these medications are, first of all, less effective most of the time than botulinum toxin. And also they are associated very often with side effects like sedation. They're basically muscle relaxants and tranquilizers that can be very helpful if there is a lot of stress involved. I saw a quick question in the chat saying, can stress make dystonia worse? The answer is a big yes, unfortunately. So obviously, if that's a big factor, maybe a benzodiazepine, maybe an SSRI can be inserted in the complex regimen. But in general, the medications specific for dystonia are not my first choice because of the higher risk of inserting other side effects, cognitive side effects, constipation side effects, urination side effects that we really don't need to add on to the syndrome of Parkinson's disease. So adjusting levodopa, if that is something that we think might happen, might help. Botulinum toxin, and eventually, as a third choice, other medications that can help relaxing those muscles.
So, if I'm going to go pursue a Botox injection, do I go to my movement disorder specialist, a PT? Who's the right person to deliver a Botox injection for Parkinson's and dystonia?
So in general, I mean, disclosure, I'm a movement disorder specialist. So I will always tell you to go to a movement disorder specialist, if anything else, because we are specifically trained to inject botulinum toxin, how to target the muscles, how to choose the doses, how to identify also which muscle pattern is involved in the abnormal contractions of dystonia. Although physical therapies or rehabilitation specialists can definitely have a major expertise in that. So if someone that has expertise and training, it doesn't have to be a movement disorder specialist. I think many neurologists that are not movement disorder specialists do acquire an expertise and specialization in botulinum toxin. But in general, it would be ideal to go to someone who's also how can I say, able to holistically look at the disease, not just inject the Botox and then goodbye, but coordinate the medical treatment, the botulinum toxin treatment, and the lifestyle discussion in the same patients. So that's where the movement disorder specialist, with the disclosure that I obviously have a bias in that favor, might be ideal for our patients with Parkinson.
Well, it makes sense to me that you would want the most knowledgeable person who has the most training to pick apart all the nuances here, especially in the context of how you defined dystonia earlier, given that it can be it can derive from all these different parts of a human's life. So I think we should probably move on to another important topic, which you have some expertise in as well, which is the relationship between DBS, which is another potential treatment for dystonia. And I think there's probably some interest in that. So I think we should go there. Tell me about that. What about DBS for dystonia and Parkinson's?
So DBS, deep brain stimulation, which has been defined the second revolution of the treatment of Parkinson's disease 25 years ago after levodopa, obviously, is an extremely, extremely effective treatment of Parkinson's disease symptoms in general and dystonia in particular. In fact, primary dystonia, if I can be a little excursus here, primary dystonia is probably the most responsive movement disorder to deep brain stimulation, in part because primary dystonia tends to be less progressive and not associated with neurodegeneration than as compared to Parkinson's disease or even essential tremor. And so we assume that once you fix it, so to speak, it tends to continue to, the brain tends to continue to work more normally. That said, deep brain stimulation for Parkinson's disease is an extremely, extremely effective treatment when indicated. And dystonia is one of the components that tend to respond the best, together with tremor and also, of course, motor fluctuations. There are two targets that we can use. One is the globus pallidum, the GPI, and the other is the subthalamic nucleus, which is the STN. And we tend, if dystonia is a predominant problem, we tend to use more the GPI, the globus pallidum, because we have a lot of experience with the globus pallidum used specifically for dystonia, even for primary dystonia and not associated with Parkinson. But subthalamic nucleus stimulation can also improve dystonia. There's plenty of data with phenomenal results. Like we're talking 80+%, 50 to 80% of a chance of improving dystonia specifically. So if the general progression of the disorder justify, or if the dystonia is dramatically disabling, then deep brain stimulation and of course botulinum toxin and all the other less invasive treatment that we have discussed earlier don't seem to help. We definitely go to deep brain stimulation. Of course, there are risks associated to the surgical implant, which are not enormous, but they are significant when they do occur, unfortunately. But we definitely use deep brain stimulation. Is definitely one of the most powerful treatment for dystonia and for Parkinson in general that we have.
What about settings? I mean, is there a different approach to programming DBS if you're targeting dystonia in particular compared to tremor or some other prominent symptom of Parkinson's?
That's a very, very good question. And the general answer is yes. And in fact, for example, if tremor is the major untreated or problematic symptom, we tend to use more the subthalamic nucleus. There's a lot of discussion among experts, but we tend to go more to the STN if we are looking mostly to stop that disabling tremor. And as I said already, for dystonia, we tend to go more to the GPI. But the problem with Parkinson, unfortunately, is that there's not only dystonia, or there's not only tremor, or you have the rigidity, you have the fluctuations, you have the dyskinesias maybe. And in this case, by the way, dyskinesia and dystonia tend to be grouped in terms of DBS indication with the GPI. And then it takes, like for every deep brain stimulation application, a little bit of expertise in how to use the electricity. I always like to to say it's not deep brain implantation, it's deep brain stimulation. So we need to stimulate the brain, and we don't just turn it off and it works. And the specific problem that we may encounter with dystonia is that while the tremor, notoriously, we all see the the videos and the YouTube videos of patients that stop their tremor in front of your eyes almost immediately after you find the critical stimulation settings. Dystonia that tends to take time. That maladaptive plasticity needs time to kind of untangle. And so that presents some challenges, because if a symptoms goes away in front of your eyes, you know you're doing the right thing. If you have to wait 2 or 3 weeks or 4 weeks or sometimes 3 months for the symptoms to improve, you're wondering if you're doing the right thing and you just need to wait, or if you're completely in the wrong space and you can wait all your life and you're just not affecting the disorder. So that requires a lot of experience. We are starting to, technology is starting to give us a lot of phenomenal tools. We can now sense abnormal activity in the brain and using to focus our stimulation settings in that area. We have AI-generated, settings that help us filling that sort of sweet spot with the effective stimulation. But there's still a lot of educated guessing still from the programmer, and it works because it works, but it's not for dystonia. I mean, it's not a quick fix. So both the doctors and the patient need to really work together and find the right setting.
Yes,
but it works. That's the bottom line. It works. I've been on record to say, if dystonia doesn't go away, it's because I, the physician, the programmer, I'm doing something wrong. Because dystonia should respond in the vast majority of cases to proper deep brain stimulation.
And so one of the factors that I assume is careful decision and discussion with the team that's going to be involved in DBS procedures to make sure that if you want to target dystonia, that should be talked about early in the process, right? Because that's going to maybe be a factor, yeah?
Yeah, this is, I have to say, it's pretty much routine, meaning when we approach the brain stimulation, which, as you can imagine, is not an easy choice for anybody. But when we approach the brain stimulation, one of the most important things that we approach and we teach also to our fellows, to anybody who wants to learn from us, is to manage expectations. So you want to understand what is the major problem that we are trying to affect, and so guide the expectation of how much that, if everything goes well, of course, may take. If it's something that we expect to improve 100%, let's say, like tremor to go away completely, or sometimes maybe the walking does not improve 100%. There are many different situations. So for dystonia, definitely we are pretty optimistic in terms of DBS, but it may take time. And that is something that needs to be discussed, and people need to be prepared. Otherwise, it can be very disappointing, to go 1, 2, 5 weeks without any visible improvements. You start wondering, what did I do this for? So it's our business, it's our duty to set up the proper expectations without being unnecessarily negative or pessimistic, but definitely trying to give, either by experience or by knowledge of the literature, what we expect to happen.
Let's jump back to a question that I sort of jumped over, which was just to ask you about sensory tricks. That's another fun topic here. Can you tell me what's a sensory trick and how does that relate to dystonia?
This sensory trick is a curious event that many patients with dystonia experience, which consists in the relief of the abnormal spasm, contraction postures just by a sensory stimulation. Sensory stimulation can be as simple as touching your own cheek, or putting the head behind your head. And there are many sensory trick. Some people with mouth dystonia put like maybe a toothpick in between their teeth, and that relieves the involuntary contractions. And it introduces, it's very interesting scientifically because it introduces a sensory aspect in what is considered a movement disorder. That's why I said that the muscles are not the problem, is the way the brain integrates sensory and motor sensory input and motor output to sort of coordinate the way we move and we organize, we coordinate our movements. It's something that patients use to their advantage, and we encourage to do it anytime they can, but it's not universal. Not every patient with dystonia has a sensory trick. And we were discussing about that earlier. It tends to be more something that I see in patients with primary dystonia, in part because dystonia in patients in Parkinson tend to affect your feet, your trunk. They tend to be less sensory trick for dystonia in Parkinson, but it's definitely something that it's found serendipitously most of the time. Literally, patients start touching their face and they notice that their neck stops pulling, and it's something that we have been using to study the pathophysiology of dystonia, but it's not something that we can prescribe. You see what I mean? It's something very, very sui generis. Is very, very limited to the single individual. And so I can't tell somebody with dystonia that touch your cheek 5 times a day. It's not going to work. They need to find it themselves, and it's not always the case, unfortunately.
Yeah, somebody just chimed in the chat saying that they found that their foot dystonia, I think it was their foot dystonia, was relieved when they put their foot on a cold floor, for example. Just
there you go.
So these are, maybe it's individual. So maybe there's like a little bit of serendipity here.
Absolutely. And that's frustrating, of course, because I would love to prescribe sensory trick. That would be amazing. So there's no side effects virtually. Yeah. But at least as far as I understand, you cannot predict the sensory trick, not even based on the specific type of dystonia, because even for the cervical dystonia is what we classically describe sensory trick. Someone touched their chin, someone touched their back, someone touched their chin. It's difficult to predict it.
So we had a lot of questions about the feet, actually, and I wonder if you might talk a little bit about that area of the experience of dystonia in the foot. Any tips, tricks, concerns, anything you've learned over your experience treating people with dystonia about managing foot dystonia?
Yes, not surprisingly, because foot dystonia is by far the most frequent type of focal dystonia affecting patients with Parkinson's disease. It is usually affecting the side of the body that is most affected by the disease. We all know that in the vast majority of patients with Parkinson's disease, one side is always worse than the other, usually the side where the symptoms started in the very beginning. And that's where usually the dystonia becomes an issue. Again, dystonia being a symptom of the disease. And for some reason, the foot affects, I think it's more than 40%. Between the foot and the toes, it's more than 40% of the all sort of cases of dystonia with Parkinson's disease. So virtually half of the dystonia, when we talk about dystonia, half of the cases involve the foot. And that can be something minimal, like something that is just a nuisance. But in many cases, unfortunately, the contractions of the toes and the foot gets in the way of walking. Because patients cannot put the foot flat on the ground, and sometimes the foot is also bending inward, and so the patient end up putting only the side of the foot on the ground, and that inevitably can cause limping at the minimum, but also loss of balance, and it can be very painful. So that is one of the most frequent situation in patient Parkinson's disease. How do we go after that? In foot dystonia, in the vast majority of cases, we use botulinum toxin. It's a very, very simple injection. It's not fun because the needle needs to be inserted under the foot, like under the sole of the foot, where the the toe flexors are, and sometimes on the side of the foot where the muscle that bend the foot inward are. So it's not fun. In fact, we use some pain reliever, some cold spray to kind of reduce the pain of the needle going through a very sensitive skin. But by the same token, can be very, very effective. And in fact, I have many patients that come regularly every 3 months to repeat these injections because it allows them to relieve that dystonia, put down the foot, walk more normally, improve their balance without, as we said earlier, messing around with the sometimes finely tuned doses and intervals of carbidopa, levodopa, or whatever else we're using. So very important, very frequent. If you have dystonia, most of the time is the foot. Can be very disabling in terms of walking and balance. But the good news is that it's very, very sensitive to a relatively simple injection with relatively small doses. And last but not least, normally approved by Medicare and insurance. So not too much of a battle to get it approved.
Yeah, thanks for that additional nugget of information there. I think that's an important component for a lot of people. Parkinson's can be quite expensive. So another thing another part of the body that we've gotten a lot of questions about is facial impacts of dystonia, and also head and neck more generally. Any sort of large, big picture perspective on those two places, head, neck, face?
Yes, absolutely. So head and neck is, in general, if we look at all the type of dystonia, not only Parkinson's disease, head and neck is the most frequent side of dystonia. Cervical dystonia, as we call it, or torticollis, is the most frequent type of focal dystonia. Fortunately, in patients with Parkinson, it's not the most frequent. It can happen, but it's not the most frequent. And the face even less. Usually, if the face starts making some grimacing movements, that's more dyskinesia than dystonia, and needs to be looked at as a problem with the dose of levodopa. Although in some cases people can start blinking a lot or even squeezing their eyes, it's called blepharospasm, and that can be described in Parkinson's disease. Again, not the most common, but it can happen. And again, facial and cervical dystonia are extremely sensitive to proper botulinum toxin injections. So if that happens, it's another situation in which I would personally immediately offer botulinum toxin, unless there is an obvious correlation with the medications that we feel we need to address.
As we round out the conversation today, I guess I wanted to ask you something about just if you have a sort of both a first step you would recommend somebody take if they think that what they're experiencing may be dystonia. I think you've already talked about that a little bit in terms of your advice about what to bring to your movement disorder specialist or your doctor. But if you have any sort of first step, if you think you're dealing with dystonia, what can you do to respond to that? And also maybe what's one thing you wish everybody with Parkinson's knew about dystonia? And maybe before you answer those two questions, both the first step and what do you wish everyone that has Parkinson's, or what's one thing you wish everybody with Parkinson's would know about dystonia? I just want to share something that was written to me when I was planning this webinar a little bit. It was a question from from a friend of mine who lives with Parkinson's, and she said, I really don't know what to do when I'm feeling almost paralyzed by dystonia. My back and my head, and I feel like I can't move because of all the pain. And I realize I'm saying this at the end of a conversation that it maybe is a difficult time to say this, but that's what this can be like for people. We can really suffer in this with dystonia. We can be stuck places because we can't feel confident going out. We don't know when the dystonia is going to hit. We don't want to be in public and sort of get stuck in that sort of painful moment. So part of the reason I asked this question about what do you wish we knew and what do you think people should do when they experience dystonia is to sort of give us a way to address that question. What do we do when we're stuck because of this? We feel paralyzed. We can't go out because we're afraid of the pain. Do you have any advice for how we can manage that difficult experience of dystonia? And I guess other parts of Parkinson's can be that way too. I'm sorry to ask you such a complicated question at the end, but.
So I'll start from the easy one, if you don't mind, which is what I want people with Parkinson's disease and suffer from dystonia is to understand that dystonia is treatable. And that's a very, very important concept, because and we went through, many different ways, but dystonia is treatable. Now, the problem might be to recognize it, and so one thing to think is and not to sweep it under the carpet. So if you feel that the muscles are twisting, they're cramping out of sort of proportion, don't think, oh, that's just a normal symptom of Parkinson, but immediately call your specialist, your provider. But someone may come back to me and say, yes, but I can't call my provider 3 times a day, every day. It would be impractical. He probably would stop listening to me. But seriously speaking, what can you do if, as you mentioned, if you're stuck with that? So first of all, don't be afraid with the guidance of a physician to use pain medications, because pain is probably the most crippling problem. And there are many levels of pain medication. I'm not going to get into specific drugs. I'm not endorsing using opioids or anything like that, but there are simple anti-inflammatories that can help with muscle pain that can be used, again, under your provider guidance. Also, dystonia, as I mentioned earlier, can be very, very sensitive to stress and anxiety. And so, which can be primary, so to speak. Someone may be anxious, maybe because of Parkinson's disease or for whatever reason, or it can be secondary. The dystonia comes in, the pain kicks in, and I'm started to become hopeless that this will go away. And that becomes sort of a self-fulfilling prophecy almost. So to address these potential triggers of dystonia, like stress and anxiety, I understand it's easier said than done because stress is part of life. But anxiety can be treated, and there are a number of lifestyle practices that can reduce the level of stress, like meditation or just socializing. I know that is sort of counterintuitive, like I don't want to socialize if I'm in pain and I have dystonia. But sometimes if we are lucky enough to have supporting friends or family, that's exactly the time that we need them. It is, again, I'm the first to admit it's easier said than done, but we don't need, one thing I always like to tell my patient, we don't need to let Parkinson drive our car. Let's put it in the trunk and let's be proactive. And even if it's something painful, there are medications for pain, at least temporarily, until maybe botulinum toxins or medication adjustment can give us a more sort of long-term solution.
Yeah, I really appreciate that answer, Dr. Tagliati, because I think what I take from it is, if you're experiencing a problem, you don't always have to tackle that problem directly. You can go around the side of it sometimes. And I think, getting to the stress component, getting some better sleep, those things that you might not jump to when you're in that difficult moment. So yeah, thank you very much for that answer. I think it's empowering because it gives us an opportunity to take a new approach to something. And I think that's sometimes what we really need.
Absolutely. And thank you for all those clap in hand and thumbs up. And I'm sure they're mostly for Chris, who put together this beautiful program. But if they're for me, I truly appreciate. Thank you.
Well, I'm sure they're for you, not for me. But thank you for the kind words, Dr. Tagliati, and for sharing so much of your time with us today.